removed. All right, this figure is in your notes, and we're going to look at the varying levels of maternal serum AFP. Here we have, in a color format, that same table. And what we're looking at here is the varying levels of maternal serum alpha-fetoprotein. The MSAFP values are expressed in terms of MOMs, multiples of the mean. A normal value is from 0.75 to about 2.5. And this is a normal right here. This red curve shows the normal distribution of MSAFP values in normal babies. If you get a level which is 7 or 8, that is incredibly high and is almost always associated with a severe abnormality, in this case, anencephaly. You can see there is no overlap between the red curve and the orange curve here. This is the curve for open neural tube defects, which would be a spina bifida. And you can see the blue curve has essentially no overlap with the red curve. These are fairly similar. Notice the black curve here. When the curve is down low, when the values are low, it was found that there was an increased risk of trisomy 21. So a high value associated with neural tube defects, either anencephaly or open neural tube, but if it's low, it is going to be a higher rate of trisomy 21. Now, is there any overlap between the black curve and the red curve? And the answer is yes. Most of this is overlap. And when you look at the numbers, the low AFP will pick up only 25% of trisomy 21 babies. The rest of those babies who have trisomy 21 will have levels which are in the normal range. And it was because of the poor sensitivity of the MSAFP alone to pick up Down syndrome that the additional markers were added, which now are included in the triple marker screen and the quadruple screen. So we have the AFP, as we said, goes up. The most common cause of MSAFP is, remember what we said? Dating error. Therefore, the next step in management is ultrasound. Does that identify what the cause is? Neural tube defect, ventral wall defect, twins, bleeding, renal disease, sacrococcygeal teratoma. If we've got the diagnosis based on ultrasound, that's the end of the line. You've already made your diagnosis. If the ultrasound does not explain why the elevated AFP, our next step in management will be amniocentesis. And specifically what we're looking for is amniotic fluid AFP and ACHE. What's ACHE? Acetylcholinesterase. You can have an elevated AFP in other than neural tube defects, but the acetylcholinesterase is specific for open neural tube. And so if we're going to do this, we're going to do both the AFP and the ACHE, and since you already have the amniotic fluid, we'll do a karyotype as well. All right, important to remember, this is not a routine prenatal test, it is an elective test. Why is that the case? Because you can have elevated MSAFP in the presence of a normal fetus. You can have an abnormal fetus, but a normal MSAFP. So it's not a diagnostic test, it is a screening test only. And intelligent, committed moms may say, I don't want that test, and I say, that's fine. Or others will say, I'd like to have it. I say, that's fine too. Because it's not a diagnostic test. Okay, if we have an elevated MSAFP, next step in management is ultrasound. Specifically, we're going to look for dating errors and for any gross anomalies. If there is a dating error, Then we can recalculate the MSAFP based upon what we now know is the true dates. If that is normal, no further workup is needed. If the dating is correct and it doesn't explain why it's high or low, the MSAFP is a true positive, then what we need to look for is there an abnormality in the fetus? Neural tube defect, ventral wall defect, etc., etc. If that explains it, we're done, because you already have the explanation. If the dating is correct and ultrasound is normal, no fetal anomalies, unexplained elevated MSAFP, then you go for a amniocentesis, and we just talked about that. Okay, let's look at an example. We do an MSAFP on a patient, and it's high. Our belief is she is 15 weeks gestation. Next step in management, ultrasound. Oh my, we find that she's actually 19 weeks. That's a normal value for 19 weeks. It is adequately explained. No further workup needs to be done. If we have a low MSAFP, our concern, of course, is Down syndrome, but the most common explanation is dating error. Next step in management, OB ultrasound. Does that explain it? Trisomy 21, do we see a thickened nuchal skin fold? Do we see a short femur? Do we see choroid plexus cysts? Do we see cardiac defects? If we can explain it, fine. But if we can't, amniocentesis specifically for karyotype. Now, if you're taking the amniotic fluid out anyway, you're going to do a maternal, or I should say an amniotic fluid AFP screening for neural tube defects as well. All right, let's look at an example of a false low AFP. Here's a patient who our best information is she's 19 weeks gestation. And you can see this is clearly low. Next step in management, ultrasound. Well, we find she's actually 15 weeks. And when we replot that, we find it is quite appropriate for gestational age, and we have corrected and explained it. No further need to do any follow-up. Okay, because of the low sensitivity of the maternal serum AFP for Down syndrome, additional screening markers were brought in, which include the beta-HCG and the estriol. And this is now used throughout the country to increase the sensitivity for the pickup of Down syndrome. And you can increase the sensitivity from 25% up to 65 to 70%. In some areas of the country, they are advancing this from a triple to a quadruple screen and adding to the MSAFP, beta-HCG, and estriol, a fourth marker, which is inhibin A. And that then increases the sensitivity for Down syndrome up to 85 to 90%. But this is not the standard of care at this point, but the triple marker screen is. AFP, remember, goes up. Estriol goes up. Beta-HCG, after 10 to 12 weeks, goes down. And the important thing to remember here is that these values are not static. They're changing. And so it's really important to know what is the gestational age. The triple marker screen, and we will often use an abbreviation, which is XAFP for expanded AFP. Geneticists use this as a shorthand. The expanded AFP is done at the same gestational age as the MSAFP, which is 15 to 20 weeks. But remember, again, the MSAFP is never done nowadays in isolation. It is always done as part of a triple or a quadruple screen. Now, this would be a great board question. What is the profile that you'd expect with trisomy 21? The MSAFP is low, the estriol is low, the beta-HCG is elevated. That's a good board question. Next step in management, anytime you have an abnormal screening test, is OB ultrasound. What are we concerned with? Trisomy 21. How are we going to confirm or rule it out? Amniocentesis for karyotype. Now, a lot of these are going to be false positives. But we need to make sure that the risk of the abnormality is greater than the risk of the procedure. And the pregnancy loss rate with amniocentesis is quoted as about 0.5%. All right, another pattern on the triple marker screen is found with trisomy 18. With the trisomy 21, the beta HCG is elevated. With trisomy 18, it is low. AFP is low, estriol is low, beta HCG is low. Our concern here is for trisomy 18. Next step in management will be ultrasound. And we're going to look for the ultrasound markers which might suggest that there could be trisomy 18. But the only way that you can confirm this with high specificity is amniocentesis. So if we have an abnormal triple marker screen, we will do the ultrasound, and if that doesn't explain it, by dating error, we will go to the amniocentesis. Okay, this would be a good board question. A 21-year-old is at 16 weeks gestation. Blood type is A, Rh negative. So she's A negative blood type. Her atypical antibody test is negative. What recommendations will you do at 16 weeks? Are we going to give a RhoGAM at 16 weeks? No. When do we give RhoGAM? 28 weeks. What gestation age do we do a CVS? That's going to be between 10 and 12 weeks. The other options would be the expanded AFP or amniocentesis. She has no risk factors that would justify an amniocentesis. So what we'd want to offer her is triple marker screen, the expanded AFP. And that is the end of second trimester laboratory tests. The next section is third trimester laboratory tests. And the specific tests that we're going to perform in the third trimester are the 1 hour 50 gram oral glucose tolerance test. This is done typically at 24 to 28 weeks, screening for gestational diabetes. We're going to do a complete blood count, looking specifically for anemia, iron deficiency anemia. This is done around 28 weeks. We're going to do an atypical antibody screen to see if the woman is isoimmunized before giving her Rh immune globulin to prevent isoimmunization. And at 36 weeks, we will do a group B strep vaginal culture to determine whether we need to give prophylactic penicillin in labor. Now, we will discuss these all in detail. These will be the chapter on medical complications. This screening for anemia will be for medical complications. The atypical antibody screen we will talk about in the section on isoimmunization, and the GBS vaginal culture we'll talk about on the section on perinatal infections. And that is the end of third trimester laboratory testing. All right, our next chapter is chapter 6, late pregnancy bleeding. First, we're going to look at the differential diagnosis of late trimester bleeding. The most common cause is abruptio placenta. Abruptio placenta occurs in about 1% of pregnancies. Now, if we remember, there's 4 million births in the United States a year. That means that there will be about 40,000 abruptions. That's a fair number. Placenta previa is in about 0.5% of pregnancies at term. So abruptio placenta is 1%. Placenta previa is about 0.5%. Vasa previa and uterine rupture are rare causes. Abruptio placenta is painful bleeding. Placenta previa is painless bleeding. Vasa previa is painless bleeding. Uterine rupture is painful bleeding. And we're going to go through each of these one at a time. First, we always need to remember, could there be lower genital tract explanations for the bleeding, such as cervical? For instance, you could have an erosion of the cervix. An erosion of the cervix is where the epithelium is completely obliterated, and you have the stroma with the vessels which are exposed, which are bleeding. This is often where you have a severe cervicitis. You could have cervical polyps. I'll show you a picture of that coming up shortly. Cervical cancer would be unlikely, but it is a possibility, and it's very easy to assess that with a speculum exam. Vaginal causes. Varicosities are common, particularly in the lower extremities and in the pelvis, and they can be sources of bleeding. Lacerations, trauma, and these can be identified and should be identified with a speculum exam. But always remember, in the late pregnancy, you want to first get an ultrasound before you do a speculum exam to rule out placenta previa, because you can get big-time bleeding otherwise. Where we will spend most of our time is looking at abruptio placenta, placenta previa, vasa previa, and uterine rupture. This is a speculum exam showing a cervical polyp. Here's a cervical polyp. And cervical polyps are really outgrowths of redundant endocervical columnar epithelium. The blood vessels are one cell from the surface, can easily bleed, but are not going to have any significant impact on the pregnancy outcome. Anytime you have a patient who is bleeding, you always need to assess, is she stable? What are the mother's vital signs? That's going to assess how the mother is doing. Is she hypotensive tachycardic? How's the fetus doing? And the best way that we have of assessing the fetus is with fetal heart tones. We'll talk about that in the chapter on fetal monitoring. If a patient is bleeding, you want to get an IV going. You're going to use a large bore IV. What size are you going to use? 16 gauge. Look at